Today we'll start hematology, and the first topic in hematology is anemias and its types. So anemias can be divided into three categories depending upon the size of the RBCs or MCV: microcytic anemia, normocytic anemia, and microcytic anemia. First of all, we will discuss microcytic anemia. So, what are the causes of microcytic anemia? The most common cause of microcytic anemia is iron deficiency anemia. The second cause of microcytic anemia is thalassemia. Third cause is congenital sideroblastic anemia. And then anemia of chronic disease can sometimes be microcytic anemia. Though more commonly, anemia of chronic disease is normocytic and normochromic. And the fifth cause is lead poisoning can also cause microcytic anemia. So we'll discuss these causes one by one. So the most common cause of microcytic anemia is iron deficiency. Now, what are the things that can lead to iron deficiency? Iron deficiency is most commonly caused by chronic blood loss. Chronic blood loss, examples of chronic blood loss include menorrhagia in females and GAT blood losses. Now, GAT blood losses can be due to chronic use of aspirin or NSAIDs, which lead to peptic ulcer disease or ulcer formation in the stomach or duodenum, which can lead to chronic blood losses. And the second cause related to GAT that can lead to chronic blood loss is a GAT malignancy. And the third cause of chronic blood loss is menorrhagia. So in females, menorrhagia, and in males and overall in general, someone with the use of aspirin or NSAID, history of aspirin or NSAID use, or history of a peptic ulcer, or history of a GA malignancy. All of them can lead to a deficiency of the iron and result in microcytic hyperchromic anemia. So the first cause of iron deficiency is chronic blood loss. Now, the second important cause is malabsorption. Malabsorption, such as decreased absorption of iron in the GAT tract due to diseases such as celiac disease. Celiac disease is a common example of malabsorption in which there is decreased absorption of iron as well as folic acid and vitamin B12 as well. So celiac disease can also lead to iron deficiency anemia. Another example of malabsorption disease is chronic pancreatitis. So chronic pancreatitis can also lead to iron deficiency anemia. Now iron is absorbed mostly in the ileum. So any disease that affect the ileum can lead to deficiency of iron, such as occur in inflammatory bowel disease or Crohn's disease. So chronic blood loss can cause iron deficiency anemia, and the causes of chronic blood loss is bleeding from an ulcer, bleeding due to chronic NSAID or aspirin use, or bleeding in menorrhagia, and The other causes of iron deficiency include malabsorption diseases such as celiac disease and chronic pancreatitis. They can lead to iron deficiency, as well as diseases of ileum such as Crohn disease, which is an inflammatory bowel disease, hookworm infections such as Ankylostomia duodenale and Nectar americanus. They can also lead to deficiency of iron because they attach to the wall of intestines and result in blood loss, which is occult and present as anemia. So parasitic or hookworm infection can also cause iron deficiency. And pregnancy can also lead to iron deficiency anemia because in pregnancy, the requirement of iron is increased. What are the signs of anemia? Iron deficiency anemia. The common signs of iron deficiency anemia include chylonychia and atrophic glossitis, inflammation of the tongue that is known as atrophic glossitis, and chylonychia that is a spoon-shaped nails. And also a third one is angular stomatitis, fissure at the angle of the mouth. So these are the three important signs of iron deficiency anemia. Though they can be present in vitamin B12 and folic acid deficiency as well, but they are more common in iron deficiency anemia. How will we diagnose iron deficiency on lab results? Because there's deficiency of iron. So MCV, volume of RBC will be decreased. So decrease MCV, hypochromia, decrease MCHC. The important lab values that you need to remember are serum iron, serum ferritin, and total iron binding capacity. You need to remember these three to differentiate between different causes of iron deficiency anemia. To differentiate between different causes of microcytic anemia. So the common cause of microcytic anemia is iron deficiency anemia. And in iron deficiency anemia, what will happen to serum iron, serum ferritin, and total iron binding capacity? Because iron is deficient, so serum iron will be decreased, and iron is deficient, so iron stores will also be depleted, so low serum iron and low serum ferritin. And as there is no iron available for binding, so total iron binding capacity will increase. These three values are important to remember for Plab 1 exam. That is because iron deficiency anemia causes microcytic anemia. So it's understood that MCV will be decreased and mean corpuscular hemoglobin concentration also be decreased. Serum iron, serum ferritin, they will be low and TABC will be high. Total iron binding capacity will be high because no iron is available for binding. So the binding capacity of the binding molecules will increase in iron deficiency anemia. Treatment is very simple because it's a deficiency of iron, so we'll give oral iron, such as ferrous sulfate for at least 3 months. And when we will go for a blood transfusion, if HB is less than 8, then we'll go for a blood transfusion. But if HB is if someone has a history of heart disease, ischemic heart disease, then the indication for a blood transfusion in ischemic heart disease is an HB of less than 5. So people with a history of ischemic heart disease will transfuse blood if HB is less than 5. And in general, will transfuse blood if HB is less than 8. This was all about the common cause of microcytic anemia, that was iron deficiency anemia. Remember that in exam sometime they will give you a question uh, in which there will be history of normal hemoglobin level with microcytosis. Normal hemoglobin level with microcytosis. You will think about polycythemia rubra vera, because in polycythemia rubra vera, hemoglobin formation is increased or RBC formation is increased. But polycythemia rubra vera can lead to decreased production of other cell lines such as platelets. So polycythemia rubra vera can cause bleeding. And due to bleeding, iron deficiency can result. So this iron deficiency will cause microcytosis, but with normal hemoglobin level. Because of excessive proliferation of RBC or myeloid cells, the HbA will be normal, but due to iron deficiency that is secondary to bleeding, microcytosis will be there. So remember that normal hemoglobin with microcytosis, you will suspect polycythemia rubra vera. Remember that chronic diseases, anemia of chronic disease, the red blood cells are often normochromic and normocytic, but sometimes they can be microcytic and hypochromic. So there are two chronic diseases that you need to remember specifically, which can be associated with microcytic and hypochromic anemias, and that is rheumatoid arthritis and Crohn's disease. So these two chronic diseases are associated with microcytic and hypochronic anemia. While on the other hand, all the other chronic diseases such as end-stage renal disease, they cause a normocytic and normochromic anemia. Angular stomatitis and atrophic glossitis or sore red tongue can be observed in both B12 deficiency and iron deficiency, but stomatitis is more of a sign of iron deficiency. And chylonychia is also typically seen in iron deficiency. So they can be seen in vitamin B12 deficiency, but they are more common in iron deficiency. So the lab finding of iron deficiency anemia is low HB, low MCV, low ferritin, high TIBC, and high red blood cell distribution width. And the deficiency of iron can be caused due to chronic blood loss. It can be caused due to increased requirements such as in pregnancy, and it can be caused by malabsorption such as celiac disease. So we discussed that there are two chronic diseases which can be associated with microcytic and hypochromic anemia. Uh, as an example, we discussed two diseases. One is rheumatoid arthritis and the other one is um, Crohn's disease. But you know that the patient with rheumatoid arthritis, they take two medications. One is NSAID for pain, for joint pain, and the second one is folic acid antagonists such as methotrexate or anti-folic acid drugs. So in patient with rheumatoid arthritis, they can have a macrocytic anemia or they can have a microcytic anemia. So if a patient with rheumatoid arthritis is having a microacidic anemia, low HB and low MCV, then the cause will be a chronic GAT blood loss due to NSAID use. And if the patient with rheumatoid arthritis has low HB and high MCV, then it will suggest folate and deficiency. So focus on patient with rheumatoid arthritis, low HB and low MCV, the cause will be NSAIDs or chronic GA blood losses due to NSAID. And if the patient is having low HB and high MCV or macrocytic anemia, then the cause will be methotrexate, which can lead to iron deficiency, because methotrexate can cause folate deficiency. So there are three scenarios that can be present in patient with rheumatoid arthritis, and that is on NSAIDs and methotrexate. Low HB, low MCV, the cause will be GA blood loss due to NSAIDs. Low HB, high MCV, cause will be folate deficiency due to methotrexate, and low HB and normal MCV, the cause will be anemia of chronic disease. How you can differentiate between anemia of chronic disease and iron deficiency anemia on the basis of lab investigation. Remember that in anemia of chronic diseases, that is associated with chronic inflammation, what happen in chronic diseases that inflammatory cytokines are released. So these inflammatory cytokines, what they do, they decrease the iron that is available, or you can say that these inflammatory cytokines, they increase the storage of the iron. They promote the storage form of iron, that is ferritin. So this iron is not available in free form for erythropoiesis. So a patient with rheumatoid arthritis and on NSAID and methotrexate, he present to you with low HB and low MCV. The cause can be either due to a GI bleeding from NSAID use, or it can be anemia of chronic disease. How will you differentiate between these two causes? In iron deficiency anemia, that is due to GI bleeding, serum ferritin will be decreased, or storage form of iron will be decreased. While in case of anemia of chronic disease, decreased free iron, total iron binding capacity will also be decreased, because there is no deficiency of iron in anemia of chronic disease. Iron is present in the body, but the body promotes its storage form, so free iron is not available. Bound iron is present, either bound in with the transferrin, that is total iron binding capacity. So the transporter of iron is occupied, so TIBC will be decreased and ferritin will be increased. So in iron deficiency anemia, decreased iron, decreased ferritin, storage form of iron is also depleted in iron deficiency anemia because of iron deficiency, and increased TIBC. While in anemia of chronic disease, only free iron will be decreased. TIBC will also be decreased and not increased, and ferritin will also be raised. I hope this point is clear.
Why is ferritin raised in an anemia of chronic disease?
In anemia of chronic disease due to chronic inflammation, the inflammatory cytokines that are released, they promote the, or you can say that they decrease the free iron that is available in the plasma or in the serum. So iron, the bound form of iron is increased, and the storage form of iron is also increased, because these inflammatory cytokines, They promote the storage of iron, because in a disease state, you can say that the body try to hide the iron either in the bound form or in the storage form. So that's why TIBC is decreased and ferritin is increased, because in chronic diseases the storage form of iron is increased, so raised ferritin, and the free form of iron is decreased. Again, the cause is inflammatory cytokines that are released during chronic diseases. So that's why. While in iron deficiency, because there is iron deficiency, the body does not have enough iron. So the body utilizes the stored iron, that is ferritin. So ferritin will also decrease in iron deficiency. And also the bound form of iron would also decrease, because there is overall shortage of iron in the body. So iron binding capacity or TIBC will be increased in iron deficiency. Is that right?
It's not clear to me.
I'll repeat again. In iron deficiency anemia, iron is deficient. There is deficiency of iron due to either a blood loss. So total iron is decreased in the body.
Right.
While in anemia of chronic disease, there is no such case. The total iron is not decreased. That's why we are not saying that it's iron deficiency anemia. That's why we are giving it a name of anemia of chronic disease. So what happened in anemia of chronic disease, that the total iron is not decreased. The total iron is normal. Now the percentage of iron that is stored or that is in the bound form, they increases due to release of inflammatory cytokines. And free iron is not available for erythropoiesis. So that's why decreased iron, and because of release of inflammatory cytokines, storage form of iron is increased, so raised ferritin, and bound form of iron is also increased. And because all the receptors of iron binding proteins are occupied, so total iron binding capacity will also be decreased.
Right.
Is it clear now?
Yes.
Let me show
Thank
you a
you.
diagram. So basically, in anemia of chronic disease, you can see that systemic inflammation and release of cytokines and interleukins and tumor necrosis factor or interferon, all the chemicals they are released. So what these chemicals do, they can lead to 3 or 4 effects. That is increase hepcidin secretion and decrease secretion of erythropoietin and decrease iron sequestration in reticuloendothelial system. Iron become unavailable for erythropoiesis. In chronic diseases, basically the body stored the iron, so it become unavailable for erythropoiesis. Because the body stored the iron, so ferritin will be increased in anemia of chronic diseases. Is that right, everyone? So a person with a history of rheumatoid arthritis, and he present to you with low HB and low MCV, and they ask you about the cause of his or her anemia. You can say it is either a anemia of chronic disease or it is anemia of iron deficiency anemia. because how you are going to differentiate between iron deficiency anemia and anemia of chronic disease? What are the 2 points on the basis of which you will differentiate between these two? Iron will be decreased in both of them. Free iron
Yeah,
will be decreased. Yes.
total iron binding capacity. This will
What
be
will be?
increased in iron deficiency anemia while it will be decreased
Yes.
in the chronic.
So why will it will be decreased in iron
Because
deficiency
there is
anemia?
already deficiency in the stored form and also the free iron, both are decreased.
Yes, because overall or total iron will be decreased in iron deficiency, while in anemia of chronic disease, uh, overall iron is normal. Only the percentage of iron that is free is decreased, and the percentage of iron that is in stored form that is increased because of the release of inflammatory cytokines. So this is how you can differentiate between anemia of chronic disease and iron deficiency anemia in a patient with history of rheumatoid arthritis on NSAID and methotrexate. Low HB, low MCV, it can be anemia of chronic iron deficiency anemia or anemia of chronic disease, and low HB and high MCV, it can be folate deficiency from methotrexate. So remember that normally anemia of chronic disease is normocytic and normochromic. But in case of rheumatoid arthritis and Crohn's disease, because they are chronic inflammatory conditions, the anemia of chronic disease is hypochromic and microcytic. So an example is given. A woman presents complaining of fatigue and heavy menstrual bleeds. So fatigue is a symptom of anemia. Pallor and fatigue are symptoms of anemia. So if someone present to you with fatigue, then the cause will most likely be anemia. She has a history of heavy menstrual bleeds, so menorrhagia is the cause of her anemia, and her HB is 88, that is low. MCV is 67, that is also low. So low HB and low MCV, and due to chronic blood loss, the diagnosis is microcytic hypochromic anemia. That is secondary to menorrhagia. So what would be the treatment in this case? The woman HB is 88. Do we need to transfuse blood, or we can manage her medically with oral ferrous sulfate?
Oral ferrous sulfate.
Yes, oral ferrous sulfate will be given because the indication for blood transfusion is if the HB is less than 8 or less than 8 or less than 88, less than 8 or less than 80. So we have discussed two causes of microcytic and hypochronic anemia. One was iron deficiency anemia, and the second was anemia of chronic disease in rheumatoid arthritis and in Crohn's disease. Now, the third, yes,
Of chronic these cytokines, it causes decreased electrophoresis and iron sequestration done and electrocyte lifecycle been reduced so that free iron is not available, but stored iron is available. That creatine increased and total iron is reduced. And stored for so TLC also reduced, right?
yes, that's right. The bound form, remember in simple in one line, if you want to remember what happens in anemia of chronic disease is that the total iron is not decreased.
Mm-hmm.
the distribution of iron in free form and in bound form and so storage form, that is changed. So the iron in free form is decreased due to the release of inflammatory cytokines, and the iron in bound form and in storage form is increased. So that's why TABC is decreased and ferritin is increased in anemia of chronic disease.
Correct.
Is it clear?
Yes, thank you very much.
Okay, the next cause of microcytic anemia is thalassemia. You are all familiar with thalassemia. So thalassemia can also cause microcytic anemia, but this microcytic or microcytosis is not due to iron deficiency. This microcytosis is due to defective synthesis of hemoglobin chains or globin chains. Normally, there are 4 chains that are present in hemoglobin. So there are 2 parts of hemoglobin. One is heme, and the second part is globin chains. So either a decreased synthesis of heme portion or a decreased synthesis of globin portion, both of them will lead to decrease in the size of RBCs. So we have discussed that iron deficiency can cause microcytosis. Now, a second cause of microcytosis or microcytic anemia is thalassemia, in which there is a defective synthesis of beta or alpha globin chains. And the only anemia that you need to remember, the only type of thalassemia that you need to remember for Plab 1 exam is beta thalassemia major. Because beta thalassemia minor is usually asymptomatic, so a patient with beta thalassemia minor will not usually present to you in hospital. And alpha thalassemia, they can cause a death in vitro, so they're also not important to remember for Plab 1 exam. Only patient with beta thalassemia major will present with low HB and signs and symptoms of anemia, such as pallor, fatigue. So because of defective beta chains, beta globulin chains, what happens? Why anemia occurs in thalassemia? Because these abnormal beta globulin chains, the RBCs that contain these abnormal beta globulin chains, they are hemolyzed in the spleen, in reticuloendothelial system of spleen, liver, and bone marrow. So that's why the patient with thalassemia usually have splenomegaly and hepatomegaly because of hemolysis of the abnormal beta globin chain containing RBCs. So severe anemia, failure to thrive, splenomegaly, and hepatomegaly is present in patient with thalassemia. Again, it will cause hyperchromic and microcytic anemia. So we are discussing a third cause of microcytic and hyperchromic anemia. So this is a similar picture to iron deficiency anemia and to anemia of chronic disease. But we all know that there is no deficiency of iron. So serum iron will be normal or increase. Serum iron will increase due to multiple blood transfusion. Iron overload occur, a complication of thalassemia because of multiple blood transfusion. Iron overload can occur. So a person with microcytic hypochromic anemia, increase iron, increase ferritin, and decrease TIBC, your diagnosis will be thalassemia.
Again,
So
Dr. Again,
yes.
Can you repeat again? I couldn't.
Because in thalassemia, there is no problem with the iron. The problem is in the beta globin chains. Is that right? And
Sir,
person with yes.
So you said that TIBC is decreased in thalassemia. So why it is decreased?
Because iron is increased. Iron in the bound form will be available. TIBC will only increase in iron deficiency. If there is iron deficiency, it means the carrier of iron, they are free, and their bonding capacity or binding capacity is increased because there is no iron to bind. So only in iron deficiency anemia, TIBC will increase. Is that right? Is that right?
Okay, sir.
Total iron binding capacity means the binding capacity of the transporter of the iron, that is transferrin. So if there is deficiency of iron, it means no iron is available for binding. So total iron binding capacity will increase if there is no iron or if there is deficient iron. But in anemia of chronic disease and in thalassemia, there is no problem with the iron. So total iron binding capacity will decrease in thalassemia and in anemia of chronic disease. Is this point clear, everyone?
Yes.
Yes.
So microcytic anemia with MCV less than 76, increase iron, increase ferritin, and decrease TIBC in thalassemia. While in anemia of chronic disease, iron or serum iron or free iron was decreased. So the treatment of thalassemia is that lifelong blood transfusions are needed to maintain a hemoglobin of level of higher than 9.5 gram per deciliter, or in some author says 9 gram per deciliter. And because of multiple blood transfusion, iron overload or increase in the iron can occur. So iron chelation is used to prevent overload syndrome. Iron chelation is used in the form of oral defiprone and deferoxamine, subcutaneous twice weekly. And a histocompatible marrow transplant can offer the chance of a cure. So the management is usually supportive, blood transfusion and iron chelation. And the cure is a bone marrow transplant. What are the